I wanted to let you know this is a phase 2 trial in recurrent glioblastoma. This excluded anyone who had been previously treated with bevacizumab and anyone with a known IDH1 or 2 mutation. We allowed any number of recurrences for patients to go on in the trial. The dose that was selected was a 3-week dosing, the 625. It was an oral agent and administered in clinic. The median overall survival was 9.7 months for the whole cohort, and I should mention it was 17 patients because this arm was stopped for futility analysis. If you look at several meta-analyses that look at the overall survival of historical controls at recurrence, you see that it's roughly around 5 months. So there's certainly some variability in this, but something to kind of think about. Also exciting results in our trial was an objective response, which we saw in a 22-year-old female that had recurrent GBM. She happened to harbor the histone 3 K27M mutation. At baseline, she had multifocal disease with 2 separate lesions, and after roughly 11 months of treatment, both of the lesions have receded. The largest one had receded by about 86%, and the smaller one had receded by roughly 75%. So I wanted to spend a little bit of time talking about this particular mutation since it is the one differential of our one responder, and perhaps pose a potential mechanism by which tumors harboring this mutation may be more sensitive to ONC201. So there's a subset of glioma patients that harbor mutations in histone, and in particular the most common one is a histone 3 mutation. These are typically midline gliomas. They can occur in glioblastomas. They're also quite prevalent in pediatric types of gliomas. In addition, the mutated, so the K27M histone 3 mutation also marks the DRD5 gene in DIPG, which is one of these pediatric malignant gliomas. And when you look, the DRD5 is actually hypomethylated in mutant versus wild-type DIPG. So the thought is, perhaps this particular mutation, by inactivation of PRC2, is epigenetically modifying DRD5 so that these tumors are now potentially more clinically responsive to ONC201. It does seem that DRD5 is one of the best clinical markers and inversely predicts clinical response to ONC201. So in our patient samples, all of our patients had high expression of DRD2, but only 6 out of 17 had low expression of DRD5. 5 of those 6 patients are still alive, and 2 of those 6 have been on therapy for greater than a year. The one patient that I mentioned that was the objective responder there was absent DRD5 expression. So the thinking is DRD5, potentially by dimerizing to DRD2, works to inhibit DRD2 activity, thereby rendering cells less dependent on DRD2. So that means that having low DRD5 would potentially make you more sensitive to ONC201 or DRD2 blockade.